We've all heard the phrase, it takes a village to raise a child, but the thing that we often forget is that it also takes one to support the mother.
Well, speaking of the village, this is our podcast. I'm Nicole Harlow.
And I'm Dawn Thompson, and we're here to connect you with a village of support you need from pregnancy to parenting.
So come on this journey with us as we build your village one episode at a time. All right. Good afternoon, everyone. How is it going? My name is Nicole Harlow, and I'm joined here today with my lovely co-host, as always, Dawn Thompson. And we are chatting with Ushta Canteenwalla about a really interesting topic today. Not a typical one, I would say, but something that we all encounter throughout our pregnancy journeys, even maybe preconception, some of us, genetic testing. And diving into maybe some myths and demystifying what it means in pregnancy. So Ushta, if you'd like to just tell our listeners a little bit about yourself and how you've, gotten onto this path and why you're so passionate about it.
Yeah, absolutely. So first of all, thank you so much for having me on as a guest. I love speaking to different communities and groups, and I love that you highlighted that it's not your typical type of conversation that you have, which means hopefully there's a lot that we can learn from each other and share. So I'm a genetic counselor, and for a lot of people, even that term is so vague, right? It's not often that we hear about a genetic counselor or what a genetic counselor does. So I like to describe it as, how can a genetic counselor help? And so genetic counselors often are when you think of pregnancy and reproductive space, genetic counselors work within a high-risk pregnancy center often, or with maternal fetal medicine doctors. Oftentimes you'll meet with a genetic counselor if there's something that came up that's concerning, an ultrasound or your screening results or some blood results come back slightly elevated or abnormal. They'll often say like, oh, go talk to a genetic counselor, or if there's something in your family history. But genetic counselors also work, if there's a family history of cancer, for example, and someone wants to better understand, what's my risk of getting cancer? Should I think about testing? And the questions that we really dive into are, is now the right time for testing for you based on your age or where you are in your life? Have you had, children, not children, like that whole discussion. And, the big question is also, what will genetic testing, what information does it give you? And is that information meaningful to you? Will it change your medical management? So whether it's in the realm of cancer or in prenatal, those are a lot of the ways that we framework a lot of the questions. So I think I probably went on a big tangent when you said how I got into this. But so a genetic counselor is a master's trained individual. We have 2 years of graduate school where we're, intensive in the genetics and the human genetics, but also in the counseling side of things, because so often we're giving information that is challenging. So we learn a lot about effective communication skills, but also how to deliver really sensitive information and how to take complex things and just break it down so it makes sense to anyone. So I got started in it. I was an undergrad and I knew I liked education, I liked science, but I didn't want to become a doctor, and I thought I wanted to do research. I worked in a lab and realized very quickly, I need to talk to people. So I need a little more interaction. And I was studying for a chemistry exam and stumbled upon a book on genetic counseling, very randomly or serendipitously. And then just ended up chatting with other genetic counselors and shadowing, and knew early on that that's what I wanted to be. And most of my career has been in reproductive genetics. I worked at Columbia University Medical Center, helping run kind of their fetal program. I've worked as a manager leading a team of 20 plus genetic counselors for a lab that does telemedicine. And then, a couple of years into that, I realized telemedicine works. It's really appreciated with a lot of the people that we speak with, partly because, it's hard to find someone to watch your child while you run to and from appointments, especially if you're a fertility patient or in reproductive space. It's great to be able to do a call with your partner where you can just conference in. And it was the same time where I think, genetics started becoming a little bit more mainstream, where we heard of tests like 23andMe and genetic testing became a thing. I'd have a lot of people reaching out to me independently saying like, hey, there's something in my family history, or I'm planning a pregnancy, but I don't really know what I should be thinking about or what I can do. Or I just got these screening results and my doctor didn't really explain them very well to me, or they just threw a piece of paper in front of my face and said, pick a test. And I thought, there's a gap here, and I want to work on filling that gap. So I started my own practice called Find Genetics, and that is a very long way of telling you how I got here.
No, I love it. And so many pieces of that path honestly resonate with me. I did fertility treatments with my firstborn, and a cousin of mine actually passed at 9 months because she had thalassemia, because both of her parents had, some gene that, they didn't. I guess this was, I don't know, 22, 23 years ago. So I don't know how prevalent it was, because I even know with my first, who's 7, when I got pregnant again, there was even more testing. And then even now it's even more so. So I know even the last 5 to 10 years has been such a revolution of it. So 20, 25 years ago, probably definitely different. But I remember when I was going through that, I was like, okay, I didn't know much, but I was like, we need to get tested for this, because I know, my uncle was a carrier. Eventually, that's in my genes, and to make sure it didn't happen with our children. So a little understanding just, from that, but also your, the way you said, just filling the gaps, right? I think there's so much that we talk about on this podcast that is necessary to fill those gaps, because you really get like a pediatrician and an OB with your prenatal journey, and that's really it. So, or like you said, the doctors just throw the paper in front of people and don't really explain it. So great that you're a resource for that as well.
Well,
and I think, I'm sorry, go ahead.
No, that's okay. I just want to get into the meat of things, just because when we take up, all this space in the beginning, I really want to get into the meat of what people who are pregnant might need to know right now about what it is that you do, or the things that might come their way in early pregnancy, or, things that those tests the doctor's going to throw at them. What does that look like? And what do they need to know about it?
Right. And I think, not to knock, like OBs or doctors, like I think everyone's doing their best to get the information out. I think when you look at that initial session that an OB needs to go through when that first pregnancy appointment, it's so limited in the amount of time that they have. So their hands are kind of strapped as well, especially exactly as you said, Nicole, over the past few years, the number of tests that are offered to people has exponentially grown. So there's no way realistically that someone could sit down in a meaningful way and give you all that information. So, when we're looking at pregnancy and early pregnancy, I like to think of tests in 2 different ways. So there's stuff you can do before you're pregnant, and that's the tests like carrier screening. So when you mentioned thalassemia, that's something where a parent might be a carrier for it, meaning you have a change in one copy of your genes usually, and you yourself are totally fine. In fact, you may not even know that you have a genetic change in your family, which is why the testing can be so informative, because the big question that I get a lot from people is, do I even need to do this? Because there's nothing in my family history. Everyone's totally fine. And the reality is, you don't need to do anything, but the test can give you information about certain hereditary risks that you may have zero idea that you're a carrier for. But if your partner is also a carrier for that condition, then there might be a 25% chance that a child could be affected, or a 50% chance, depending on the way that that condition is passed on. So carrier screening simply is a blood test that looks at a number of genes to see if there's any changes in them. And you wouldn't know because you would have no health symptoms or signs. But if you are a carrier, the next step is to test your reproductive partner. And the reason I love talking about this test even before you're pregnant is because for the sheer purpose of time, right? And I'll give you an example. I talk to so many people who find out when they're about, 15, 16 weeks that they're a carrier. Well, now you found out you're a carrier now. Now we're waiting for your partner's result. We wait another 2 weeks. And now we're at like 18 weeks. So now we're talking about a situation where I'm telling you there's a 25% chance your baby could have a pretty serious condition, because a lot of the conditions that are tested for on these panels are conditions that can have a significant impact on the health, wellness, and longevity of a child. So, they aren't adult onset conditions. They're things that really can impact childhood health. So now you're telling someone about that far along in a pregnancy. We talk about testing to find out via diagnostic testing like an amniocentesis, where you're getting a piece of genetic material from the pregnancy and then you're testing it. Now you're waiting for those results, which take another 2 or so weeks to come back. So now you're close to like 20 something weeks. That's a long time to wait and be anxious about trying to find out about results. Whereas if you kind of did this ahead of time, you would find out if you're even at risk or if you even have anything to be concerned about. And then, the beauty of that is also you're given so many more options. You can say, okay, well, if we know that we're both at risk and we know that there's a 25% chance a child could be affected with this condition, well, maybe we want to do IVF and test embryos with the goal of only transferring embryos that are not affected. Or maybe IVF is not for us, and we will just test early on with the CBS procedure, which can be done as early as 10 and a half weeks gestation, and then we find out sooner than later. Or maybe we're totally fine with this condition, but we just want to be prepared and we want to know. Or maybe we want to gather more information on what this condition is and talk to other parents who have a kid with this condition. So the options are so much more available to you when you find out sooner than later. So there's that's carrier screening. Then other tests, like once you find out you're pregnant, you're about, you're 4 or 5 weeks when you might have a positive pregnancy test. And then by the time you get in to see your OB, I'd say most people are getting in around 8, maybe 9 weeks gestation. Sometimes it's pushed out a little bit depending on how busy they are. So one of the earliest things that you could talk to your doctor about, and I think often what tends to be missed at that first appointment, is if you haven't had carrier screening, advocate for carrier screening at that first appointment, right? Or even if you're calling your OB and you say like, hey, I have a positive pregnancy test, I want to come in. And they say, great, we'll see you in a couple of weeks because we want to do an ultrasound to verify the pregnancy and all that. You could even advocate at that point, well, hey, can you just write me a script for carrier screening? I want to get the ball rolling on it, right? You don't need to wait until that first appointment if it's something that they could just say, yeah, come by the office, we'll give you the script and we'll if you want it, might as well get the ball rolling. So that's one way to.
Is that something that's typically covered by insurance, or is it cash?
Yeah.
Like what?
Yeah. So carrier screening is something that is covered. Typically people find that their insurance has no issues covering it once they are pregnant. It tends to be a little tricky. Some policies are a little bit picky about, well, if you're not pregnant yet, we're not really going to test you for it. But I think that that's changing over time, and they are covering it. And then there are a lot of labs that have a pretty cost-effective program if your insurance doesn't cover it as well. So like under $200 to test kind of multiple conditions.
And I think definitely, like we said earlier, it's changed over the years, because I remember with Dylan's, like even his NIPT testing, and things like that wasn't covered. That was like this anomaly if it was covered, but then like by the time my 3rd and 4th kid, they were just like, oh, it's just included, even that, like, because you said like the 23andMe and all of that accessibility of genetic testing has shifted, it's also catching up with the healthcare system.
Yeah, and I think insurance companies are starting to realize the utility of some of it and the value in it. So NIPT is kind of the other test that I was going to segue into. So thank you for bringing that up. So NIPT is referred to as non-invasive prenatal testing. So this is a blood test that's done, and it can be done as early as 9 weeks gestation. And it's looking for the risk for some of the more common chromosome changes that can occur. So it's looking specifically at chromosome 21, 18, 13, the X and the Y chromosomes. So I think the key thing to remember here is that it's not looking at all 23 pairs of chromosomes. It's just looking at the 5 that more commonly have changes in them. So it's not looking for everything, and it doesn't give you a concrete yes or no answer. It's still a screening test. And so what I mean by that is, if results were to come back as high risk, it's super important to know that there's additional testing to be done to confirm those results. And, it's a little misleading, I think, in a lot of the marketing for the test, because it makes it seem like it's 99% accurate, right? So like that, so you're thinking like, okay, if I get a positive result, this means 99% true that this is what my baby has. But in reality, you know, there are false positives, and some of it is heavily dependent on age as well. And so one of the key metrics to look at, or numbers to look at, is something called a positive predictive value. So the lab report should have that on there. So for the positive predictive value, what that means is if it comes back and says, you know, the positive predictive value for this is 70%, that means we feel 70% sure that this is what it is, but 30% we're not. It could be a false positive, right? So it's important to look at those numbers and see what they mean. So, you know, that false positive rate will really change based on kind of the general population risk for that condition. So there's a lot of different numbers that go into it. But bottom line, I think, is that if a result comes back screen positive, just hang tight. Know that there's additional testing that needs to be done, like a diagnostic test, like an amniocentesis, to confirm what those results are.
Yeah, I mean, I started recording literally, I think maybe less than a week ago. I was talking to somebody who went through this whole process of like getting a positive when they did some of the genetic testing while they were pregnant already. And she said it was so awful, like, because, you know, she was now being referred to specialists and, you know, all and went through, and obviously lots of tears and anxiety. And in the end, the baby didn't have anything and was totally fine. But I mean, they were treating her like she was really like, it was a real big, scary thing that was coming, and that, you know, their baby would not survive delivery, blah, blah, blah. And she's like, I feel like I wish someone would have said to me, are you going to do the testing? And if you, I mean, you know, if somebody said, do you want to do the testing? And would you make a different decision?
Yeah.
You know, what's the, you know, like, would you take action? Meaning, would you
how would these results, like, would you change any management based on these results? Would you change anything if you had these results? Yeah.
And she said, and I didn't have the opportunity to think about that until all of this was already in full swing. And she's like, I wish I would have just not found out, because I think that I would have been a lot less stressed out. And I mean, we can even start having a conversation of what that does to the fetus when in utero, when mom is on this emotional roller coaster and cortisol levels off the chart, and, you know, all of that sort of stuff. But you know, she was very emotional about it, just telling me, you know, that how hard it was and how awful it was. And then to find out that her baby was perfectly healthy and there was nothing wrong.
Yeah. And I think that's why I've taken such an onus to always talk so much about, here are what these tests offer you. Like, information in advance. I think people, if they're given the opportunity to get information in advance, can make so many better informed decisions. You're able to say, like, you know what, I don't want that testing, or, you know what, I actually, like, I think in reality, I think most of us don't know what we do until something is a reality for us, as much as we can hypothetically say, like, I may or may not. For a lot of people, all of this is so abstract, and we may not know what we do unless it is a reality. And I think if you flip the scenario around for a lot of the people that I've spoken with, when it is a true positive, when that actually is, they are grateful they found out. So there's no cookie cutter magic answer. Right? I think the key point that we're all saying here is it should really be an individual decision. People should have the opportunity to get the information and make that choice for themselves, rather than, like, when I think about the experience that so many women have with genetic testing, it's like, you put your arm out for blood work, similar to, like, I'm getting my iron and my thyroid levels out, and you have no idea that that was genetic testing. Like, I had no idea I even had that done. Like, my arm's out all the time at every appointment for blood work. I have no idea what I'm getting done. And even myself, I've had, you know, 4 pregnancies, and and I'm because I know what all of this is, the experience has just been really eye-opening. Like, oh, like if I didn't know what I knew, like you shouldn't have to have a master's degree in genetics to be informed of this. Like everyone should be empowered to know this information.
I think that's a huge theme that we talk about in so many of our episodes is like informed consent, not consent, but like informed consent, technically, if you're taking blood from someone, right, to run the test, information and individualized care, right? Like with all things perinatally, like it's not a one blanket answer for everyone. And doctors who are delivering these tests or, delivering the results need to understand that it really is an individualized process and choice, rather than, oh, this is the path you take if X positive or if Y negative,
Right. It was probably the biggest thing that made me start Birthify, was because as a doula, when I practiced, the number one thing that people said was, I wish I'd had more information, or I wish I understood that I had other options, or if I would have known this, I wouldn't have done that, sort of thing. And I saw that all the time. And again, it's, for a physician's office, it's just another day, right? It's just another day, and they're trying to be as efficient as possible in their day as they're going through it. And they tend to forget that people get to make decisions about these things. Right. It's like, oh no, these are just all the blood tests we take, and you've given informed consent because we're telling you we're going to do all these tests, but we're like you said, they don't have the opportunity or the time to go down each test and be like, this is what this is for. And because they've gotten it approved for insurance to just be covered and included, it just happens a lot of the times. And then, like you said, the people get back those results and they're just like, I didn't even know I was testing for that, And, and I think that a lot of people need to be able to evaluate those options and evaluate whether or not they want those results.
So Ushta, can you tell us about some of I know, again, being through 4 pregnancies, I know what the common
tests are.
What the common tests are. I was going to say what the common ailments are that you test for, right? Like what are the potential conditions?
Yeah.
So if someone is in their first pregnancy, they're like, I don't even know what these are. Like, what are the top 5 or 10 that we want to look out?
So I think it's becoming harder to answer that question because when you look at carrier screening, for example, right, there are panels that test for up to 500 conditions, and we can get in a whole segue about is more better, and not my quick answer is like more is not always better because sometimes we know very little about some of these variants and it can cause more anxiety than not. I like the sweet spot of like the 200 something panel because then we know that, like we know enough about those conditions, we know what they mean. So those conditions are things like, some examples are like the thalassemias, which are inherited blood disorders. Cystic fibrosis is a super common condition. 1 out of 25 people will be a carrier for cystic fibrosis. So it's quite common for cystic fibrosis. So that's kind of a condition that a lot of people have heard of. So those things like that are what carrier screening will look at. Once you're pregnant, you can test the pregnancy, right? And so then you're getting information on things like risk for chromosome changes, like an extra or missing chromosome, things like Down syndrome or trisomy 18. So you're getting information on the chromosomal health. And what we know about those is that oftentimes people will say, back in the day, testing for chromosome changes used to be something that was typically offered to women 35 and above, as we kind of kindly label it geriatric pregnancy, geriatric, not so geriatric pregnancy. But it's just that at that age of 35, or actually it's 37, the rate of chromosome changes increases more rapidly. So whether you're 15 or you're 50, there's always a chance to have a child with a chromosome change. That risk increases slightly every year. And when you hit 37, it just increases at a faster rate. And the reason for that is because women were born with all of our eggs. So as we get older, our eggs get older, and the mechanism that separates the chromosomes the way that it should just becomes a little less efficient. So the rate for chromosome changes increases as we get older. So that's kind of what the NIPT is really looking at. And I'll say, you know, now there's always more and more that labs can do and technology can do. And it's a plus minus thing, right? It's weighing all those options. So now there's some labs that will add on certain micro deletions onto the panel for NIPT. And that's where we get into a lot more of the false positives, because NIPT is just not as good of a test for some of these microdeletions as it is, say, for example, looking for the risk for Down syndrome. It's a really great test for looking for the risk for Down syndrome, but your positive predictive value is pretty crappy for like certain microdeletions. And so it kind of begs the question of, do I even really want to do this test if it's likely that if it comes back increased risk that it's just going to be a false positive? And that was actually the experience I had in my pregnancy, where they were like, but your insurance covers it, so you should just do it. And I'm like, well, actually, I don't want that information because it's not a good test for this. So let's not do it. And they're like, but we don't know how to order it then. So it's kind of that, again, that whole, if insurance covers it doesn't necessarily mean you should do it or you have to do it.
Mm-hmm.
Now I'm going to throw a trendy word out there for you just to see if there's something in pregnancy that can be done, or it may be after, but I hear it all the time in like just different conversations about the MTHFR gene, right?
Oh,
like,
yeah.
Something in pregnancy that could predict that, or is that totally afterwards, or is there any kind of, like I said, for our listeners, they may be like on Facebook groups and they may see these terms or hear these terms. I just want to debunk and demystify anything that is about.
So MTHFR is, it's interesting, right? So if you look at the guidelines, like American College of Obstetrics and Gynecology, the American College of Medical Genetics, all of these guidelines have a very blanket statement that they don't see the utility in MTHFR testing in the reproductive pregnancy space. And here's why. So there are two common variants in this gene, meaning changes in the genetic code. And a lot of people have them, right? And so there are some providers and people who feel that if you have a change in MTHFR, it leads to an increased risk for pregnancy complications, miscarriage, infertility. And because it's such a common variant, it's very, very unlikely that it has an impact, because that would mean that there would be a whole lot more people who are experiencing complications that just don't. So the data, when you're looking at the data, it can be a little bit skewed, because if you look at the population of people that are having infertility or difficulty conceiving, and then you test them for MTHFR, you're like, oh, wow, a lot of those people do have a change, right? But what if we looked at every other person who walked in an OB's office that doesn't? That's an equal rate of people having that same exact variant. So it's not causative, meaning this change, if we were to test the next 1,000 people that walk past our door, would 50% of them have it? And then therefore, can we really say it's causing something or not? Probably unlikely that it is. So we're not big advocates on testing for it. However, there are certain providers that have had utility in testing for it and management of it, and it has helped people. So I don't want to completely kind of debunk it, because for some people it has been helpful to have the testing and kind of be managed for it. But from the guidelines that I kind of follow from the Obstetric Society and the Genetic Society, we're not really big advocates for it.
Well, let's talk about you. We keep talking about false positives and negatives and positives, and why don't you explain that a little bit? Because I see that there's some people who have no idea what that even
is. Yeah. So false positive is like if a test comes back and says, hey, you're at increased risk for this. Do you really have that condition, or does your baby really have that condition? So that's what a false positive is where it says, so like a screening test like NIPT, for example, if it comes back and says baby has an increased risk for Down syndrome, and then you have a diagnostic test, meaning a test that gives you a yes or no answer, like an amniocentesis. And if that result comes back and says, nope, everything looks great, everything looks normal, that is a case of a false positive. We falsely told you something was increased risk or positive, but in reality, it wasn't. So our test wasn't accurate, and our initial test wasn't accurate in giving you that information. And that's why it's called a screening test, because it's not intended or designed to give you a yes or no answer. And I think that is lost on a lot of providers as well, because it's marketed as being a test, the NIPT I'm referring to as being 99% detection rate. But it certainly does have its false positives.
Right. Yeah, I mean, of course, those are usually the stories that you hear the most of, because it's the ones that people are traumatized by.
Yeah, they're impactful stories for sure. And I think what's really confusing too, when we look at kind of the landscape of how people receive information, so often now we're receiving information through our electronic medical record. And the way that they data dump from the labs can be quite awful. So I've had patients who've received, your results are available, and of course, it's like a Friday at 7 p.m. and they're looking, and it's like it says abnormal, like it blasted abnormal, and it's a carrier screening result where they're a carrier for a condition. So yes, it's abnormal, but the way that they're reading it, and then there's the whole description of the super scary condition that your baby might be, that you're a carrier of, that your baby may have a chance of having, is listed there. And so now you're freaking out, like, what the heck is going on? And there's no one to reach out to, because you call your doctor's office, but no one's there. It's Friday night, and a lot of people at the doctor's office may not be able to interpret what it means. And then they're like, well, great, you need to talk to a specialist, you need to talk to a genetic counselor. Well, now you got to wait to speak to one. But simply, again, here's where if you have a little bit of information in advance early on, you would be like, oh yeah, that's carrier screening. If I'm positive, great, next step, test the partner, like nothing to really stress about so much right now. And, even when you're speaking to a genetic counselor, we can put it in context. We can say, well, the chance that your partner's a carrier is, 1 out of 350. Then if we do the math, like the chance that your baby's actually affected is 1 out of 8,000 something. So let's put that in perspective, right? And so like you can kind of be like, okay, yes, there's a chance, but it's a small chance, and we're taking the right steps to find out, and there's nothing more I can do right now.
So, I mean, we might as well dip our toe into the very controversial subject of what happens if you are pregnant and you do find out and you do get a positive and you do get confirmation.
Mm-hmm.
There is in some places the option to terminate. Yeah. But at this point, in many places, there is no option to terminate. Yeah. So what does that look like from your perspective when you see that? Like, because that's a big touchy subject right now.
Yeah, it's challenging. Absolutely. I think I always say the decision to do a diagnostic test like an amnio or CVS isn't necessarily about, do I continue or not continue? Because I think in the 20 plus years I've been doing this and having these conversations with people, there's no one consistent trajectory that people are on. I think everyone comes to their own decisions in their own way. So for some people, it's about getting that information and being empowered to say like, okay, well, if I know my baby is at risk for a certain condition, I want to do everything possible to line everything up once baby's born to have the right resources, right? I want to talk to the right specialist. I want to make sure we're delivering at the right place. If there's a risk for a heart defect, I want to deliver at a place that has a tertiary NICU. There's a lot of information that can be helpful from that perspective. Yeah. And for other people, they say, my threshold for having a child with complications is really low, and I'm not in a place to have that. And for whatever your reason is, it can be any reason, right? And they choose not to continue a pregnancy. That's also an option in some states, not in others, right? And so I think we try as a profession to help patients get the information they need and the resources they need to make the decisions that resonate with them.
Yeah. My sister, actually, my stepsister actually went through this and discovered that her baby didn't have kidneys, and that it was not going to be viable for life. And she made the choice of going through her full pregnancy. And I don't know that she would make that decision again.
Yeah.
Because it was pretty traumatic. And there's something to be said of what it was like after the baby came, and like that experience of actively seeing a baby shut down, you know?
Yeah.
And, you know, there's a lot of people that I don't think consider those things when we're having this conversation of like, what kind of trauma goes along with continuing that pregnancy.
Yeah, I mean,
lifelong, right?
Lifelong, yeah, and no one goes into pregnancy, right? Like everyone wants a healthy pregnancy, right? And the experience of having to give birth to a baby that is going to die shortly thereafter, and leaving the hospital without a baby, and having to do this on a labor and delivery floor, like there's so much around that, right? And it can be a beautiful process, you know. For some people, it can be beautiful and traumatic at the same time, right? Like it can be both. It's not one or the other. But to be able to give people the option to choose that, I think is key.
Yeah. Yeah. I mean, I think for her, it was just a matter of like, she didn't realize how challenging and awful it would be, you know, to go through that process after the baby had come, and like what that would look like. And I'm trying not to get into too much detail, but you know, it was pretty traumatic for everyone. So, you know, for her, I'm so glad she knew, right? I'm so glad that she found out beforehand and had all those choices to make. And even though maybe she'd make a different choice the next time, it's still amazing that she had the option, because I mean, I think it would have been far more traumatic had she not known back in the day before there was ultrasound, before there was ability to see this, and then just suddenly have to process it all. At least she had some time and she knew what was coming. She was hopeful that it was inaccurate, you know, and that the baby would be fine. But you know, gosh, I just don't envy anyone who goes through this process, whether you get a positive, false positive, negative.
No,
like,
I think that's sometimes, like, sometimes information is too much information, right? I think we run into certain scenarios where, you know, we find out that there's certain variants or certain changes and we can't completely explain it, right? Like, so baby's found to have a specific deletion, but one of the parents has it. But then there's something in the literature that says this is a big, bad, awful thing. But here you have a parent who's perfectly healthy and well who has it. How do we even make sense of that, right? And I always say, like, yeah, we're given choices, right? But sometimes your choices are just both crappy choices. Like, you're not given great options. You haven't been dealt a great hand, and it's okay. It's okay to say that, like, you've just been dealt a crappy hand, and both your choices are crappy choices, and you've got to choose between which one is less crappy.
Yeah, for sure. Man, it's such a heavy subject, really, when you start diving into these things. And like, you know, and is there anything that's happening that you know of that's related to autism?
Yeah, so so I'll start off by saying there's no one specific test that can say, like, oh yes, this is a genetic test, a change in this gene will cause autism. Because in fact, it's changes in many different genes. We're finding a lot of different genes that have changes that have autism as kind of, you know, or autism spectrum as some of the symptoms, right? So if a child has autism, then there is you can do exome testing, which is the kind of a broad genetic screen of multiple areas of the genome or the genes, and see if there's changes in it. Sometimes autism is part of a larger syndrome or other things that are going on. So meeting with a medical geneticist, so that's like a physician who had basically a pediatrician that's specialized in genetics, can do a full evaluation and see. And I'd say the benefit of that is, you know, you can connect with other families that have a child with the exact same specific variant, so you can have a little bit of a lens of what things could look like. If it's part of another syndrome, you know what other specialists you might need to interact with. You can be more targeted with the research or clinical trials or anything that's out there, right? Prenatally, there isn't necessarily a test that we would offer or do that can look for that. Yeah.
I'm just curious because, of course, I've had this theory because I have a child with autism, and she's considered, she hates me saying this, but high functioning. But I think it's really interesting that my mom has ADHD and a learning disability. I have ADHD, a learning disability, and two of my other children have ADHD and learning disability. And then Toby wound up with autism. And I just can't help but wonder if all of those are together,
They
under
are.
the umbrella, and that she actually just got just a slightly more severe version of what we already have. And because I've actually tested for autism, that like we had her take a test, and then I just thought, oh, I'll just take it just out of curiosity. I actually scored higher than her on the autism thing. So I thought, well, that's interesting,
Yeah.
but it makes a lot of sense sometimes on some things. But I'm just curious about that. Like, before we started this call, that hadn't occurred to me until we were in the middle of the conversation about what that looks like. And I know there's a lot of debate on what causes autism and whether or not vaccinations cause autism and all of that. And I'll just share here. My daughter has not been vaccinated and she has autism. So for me, I can tell you that is not what caused her autism. But that's a whole nother subject.
Yeah, I mean, I think so. You bring up a great point, right? Like family history, and what role does family history play in any of this, right? And I think again, it's something that's overlooked a lot. So when we're doing a genetic counseling session, a huge part of it is actually gathering family history. And when we see a family history where there's multiple people with similar symptoms, we would say that the chance for you to have a child within kind of that spectrum of, ADHD, like autism, is slightly higher just based on the fact that you have multiple family members. And it goes to say that we may not be able to pinpoint the specific gene, and maybe there's multiple different genes, but there is a heritable factor, and we know that. But then there is an environmental factor. These are things that we call multifactorial, right? So for example, we can have siblings with the same exact genetic change, but they present differently, right? And why is that? Even amongst identical twins where they share, their DNA is identical, but they're presenting symptoms differently. And why is that? So there's probably other environmental factors. Maybe there's some sort of trigger that sets off and activates a gene. Maybe it's in the cellular environment. We don't completely understand. We don't know, right?
My neighbor has identical twins, and the one is severely autistic, like nonverbal at 18 still, and he's about 3 or 4, mentally. And then the other one is at college right now.
Yeah.
Well, and when we started the episode, I was talking about my cousin. She was a twin as well. And the other twin is just celebrated his 24th or 25th birthday. So it's interesting to see.
Yeah. And so I think genetics has come a long way, but there's still so much that we don't know. And that's kind of the beauty and the challenge with testing, right? Like back in the day, we weren't testing for 200, 400 carrier screening conditions. And we've learned, the more we learn about variants, the more information we can give back, right? So as people test and as we learn more, the more information we can give back as we learn, and I always tell people that the people that make it to medical attention are the people that are more severely affected, right? They're the ones who are getting testing. But what about all the other people that are so mildly affected that they've never had testing, but we don't quite know? So could there be more people out there with the same exact genetic variant, but we don't completely know the full spectrum of it? Possibly, yes.
What do you have a list of the different tests that are pretty traditional?
Yeah.
So that they can look, because I mean, the thing that we didn't do today was get into the nitty gritty of these little tests. Like, I don't know. And I would love to make sure that we have some sort of download or something if you have something
Yeah,
like that?
absolutely. I've written about that. Like, here are the 6 things that are offered to you in pregnancy, and here's kind of the sequence and the timeline. And when you know that, you can just go into your doctor and be like, I want to learn more about this, or I want this, or I don't want this, right?
Yeah.
And I think I'll also preface this by saying, we've talked so much about what can go wrong in a pregnancy. We fail to realize the vast majority are perfectly healthy, fine from a genetic perspective, right?
Yeah.
We focus so much on kind of that small percentage of the what ifs and the what can go wrong, that it's a really interesting time, right? Where if you talk to kind of like a generation above, they'd say like pregnancy was kind of blissful in a way. You didn't have those extra layers, or like waiting for those results, or what could they mean, right? And there's some beauty in that. And so, but we've come a long way, and now we have it, and we can't undo what we have. Okay. But it kind of takes away a little bit of that like oblivion. And so kind of bringing that joy back into pregnancy is just my way of saying, like, vast majority, everything's totally fine.
Yeah, I'll tell you what, I chose not to find out the sex of one of my children, and it was the best decision I ever made. And if I could do it, go back and do it with all of my kids, I would do it. Because just because you can know doesn't mean that it's the best option. I just remember always feeling so much anticlimactic emotion about finding out the sex. And like, I find out the sex at whatever, back then it was 13, 14 weeks was the typical time frame. And then I remember being so excited for that appointment and and then they would be like, and it's whatever. And then you're like, oh, cool.
Okay. Yeah.
Now I gotta wait for the next 6 months, and I remember just feeling like it was kind of like, where when we waited to find out with my daughter, the whole family was so invested. Aunts, uncles, cousins, like everybody was betting. I swear the waiting room at the hospital was like 30 people deep probably. And everybody was so excited. They just wanted to know what it was. And it changed everything. So I use that as an example, of course, in a positive aspect, but
fun fact, I didn't find out with my pregnancies either, and I was literally working on the floor where the ultrasound techs knew. So I'm like, everyone zip it. Like, I don't want to know.
Yeah, and see, I'm the complete opposite. Like, I will literally go mad if I don't know throughout that entire time.
Like, what a great example of like the right decision for you is totally not the right decision for someone else.
Yeah, 100%. I think with my last I did the sneak peek test with my 3 youngest, and because I wasn't around before that, but I think with each of them got like closer and closer, so it was like earlier and earlier that I was able to find out, and I was like, this is amazing, and they were right all the time. So but for me, like, I need that like certainty, because there's so much uncertainty and like uncontrollableness. And we talked about autism, ADHD. I'll tell you, I have like OCD to the max, so it's like the obsessiveness that I feel if I don't know or have that like lack of control. So but also, like, if it was something other than gender, like, I don't know if I'd want to know that.
Right. Yeah. Well, and I think that's what we should leave on this note of, is that, and I think we did a great job here of really trying not to say what you should or shouldn't do. Right. But what we want you to walk away from this podcast episode of is, it is likely going to be presented to you at some point in your pregnancy. And you may even want, if you're not pregnant yet, it's something you may want to do before you get pregnant, but also you may not want to do any of it. And you have the option, and you get to educate yourself and have the power to make these decisions. And, information oftentimes is power. So that's how I think we should leave that.
I agree. And like we said, Ushta will definitely provide us links or a download in the show notes. And if you want to learn more, her links to Find Genetics will be in the show notes as well. So just to wrap up, Ushta, speaking of the village, besides a genetic counselor, which I can honestly say we haven't had before, who would you say is, in your experience or in your life, the most important role in the village?
Yeah, I mean, I'd say it's hard to pick and pinpoint just one, right? So I'd say broadly, anyone who you are trusting with your pregnancy journey. So whether that's a doula, a midwife, your OB, like whoever it may be, like that's the person that you form that relationship with. That's the person that you should feel comfortable asking these questions to, like, what are my options? And the reality is, like, not one person is going to fit all your needs, and like that one person should know how to refer to all the other. Like there's locations that I have, and I'm always referring people to other providers that can be helpful. So I think it's finding that provider that you feel can listen to you and honor and help you make those decisions that feel right for you, and then refer you out honestly to the places that they feel are trusted resources as well. So sorry, that's like a non-answer answer that I gave you.
Totally I love it. No, and I love this question because of that. Exact. It doesn't have to be one answer. There is no right, wrong answer. It is the truth of being a village, right? It isn't just one person. And that's what we wanted to show, is the connection amongst all of the roles. But to your point, it isn't just one person. And the person that it is that will listen to you, that will have the understanding conversations and refer you to the specialist that you need is crucial. So thank you so much for all of the information. We really, truly appreciate your time coming to chat about this with us. And thank you so much.
Thank you.
It's been super fun. Take care. Bye-bye.
Hey, thanks for joining us on Speaking of the Village. If you love today's episode, make sure to hit subscribe and share it with a friend.
And remember, you're not alone. We're here, we're listening, and we're all in this together, because in our village, no mom walks alone.